so we're going to start with House File 4779, Representative Hicks. And since Representative Hicks is not on the committee, I will move that House File 4779 be laid over for possible inclusion. And with that, and there is an A1, but we will wait on the A1. We'll present the bill and speak to the bill and then do the A1 a little bit later. So Representative Hicks, welcome to your bill.
Thank you, Chair. Thank you, committee members. Some of you serve on other committees with me, so you're well aware that children's mental health is a primary concern.
And Representative Hicks, could you just pull the mic up a little?
How's that?
Much better, thank
I
you.
forget that this room has picky microphones.
We need a new building, don't we?
This bill establishes a medical assistance benefit for children's residential mental health crisis stabilization services. The goal of these services is to better support children and families by providing the appropriate level of care in a community setting earlier in crisis. This helps prevent potential need for children in hospital emergency rooms and more invasive and expensive residential programs, which, as we heard in Human Services Policy, many times are out of state. The children's mental health crisis continues to be a significant concern in Minnesota. We know that we are short hundreds of PRFT beds. We are short outpatient providers. We are short skill providers. Our children cannot access the care they need when they need it, and they may end up in crisis. In our community, the Southeastern Regional Crisis Center, or CIRC, has been providing these services for children and youth in the region since 2021. CIRC also provides community-based residential stabilization services for adults, but these services are already covered under medical assistance. We know that our counties and providers across the state would also like to see these services be available to children and families in their communities, but the current funding model is not sustainable. Coverage through medical assistance will help ensure that children's crisis stabilization services can expand statewide to better support our children and families. That is the purpose of 4779, and I'm happy to have a testifier from our community to talk a little bit about that, and would love to invite them to join us.
All right, thank you very much, Representative Hicks. So we'll have the testifier come up. Welcome to the committee. Please introduce yourself for the record and go ahead and give your testimony.
Good morning, Chair Liebling and committee members. My name is Travis Granzi, and I'm a Olmsted County Deputy Administrator overseeing Health, Housing, and Human Services. And today I'm here testifying on behalf of Olmsted County, the Minnesota Intercounty Association, the Association of Minnesota Counties, and the Minnesota Association of County Social Service Administrators. So thank you, Madam Chair, for the opportunity to express our strong support for House File 4779. We're also grateful for Representative Hicks for authoring this legislation. House File 4779 establishes a medical assistance benefit for children's residential mental health crisis stabilization services. Many children and youth in our community across the state face difficult mental health and behavioral health symptoms each day. The current service delivery landscape, as Representative Hicks described, doesn't offer adequate community-based solutions to address the needs of many of these families. Olmsted County is proud of our local partnerships and grateful for the strong support from the Minnesota legislature that enabled us to build and operate the Southeast Regional Crisis Center. Through the CIRC, the county and local partners provide walk-in mental health services 24 hours a day, 7 days a week, including community-based residential stabilization services for children, youth, and adults. The residential stabilization services provided for adults at the CIRC are funded through medical assistance, but the same services for individuals under the age of 18 are not covered. Residential crisis stabilization services are critical for children and youth to access services needed to resolve a crisis episode. This supports families by working with individuals experiencing mental health symptoms in a community setting. The goal is to reduce more costly services such as emergency departments and child placements, as well as providing connection to ongoing services needed to prevent future episodes. Counties also support another bill on your agenda today, House File 3495, which has similar language to establish the medical assistance coverage for children's residential stabilization services. We don't have strong preferences regarding the language, but do prefer the timeline that's outlined in our bill to establish the coverage more urgently. So thank you, Madam Chair and members, for your consideration of House File 4779.
All right, thank you, Mr. Granzi. Is there anyone else who wants to testify on the bill? All right, I'm not seeing anyone else. And just backing up a little bit, I never announced that there is indeed a quorum present, so that is kind of important. Anyway, that being the close of testimony, is there any discussion to the bill? This questions. Representative Brindley.
Thank you, Madam Chair. I assume a fiscal note has been requested for this.
Would you like to hear about that? Because we do have one.
Oh, it already exists.
Oh, yeah. I'm sorry. I'm confusing it with a different one. Right, Mr. Harney?
You're like, wait.
It is kind of fog. It is a fog this morning.
Madam
Sorry.
Chair, Representative Brindley, there's a fiscal note requested for the underlying bill and the author's amendment that hasn't been adopted yet. The testifier mentioned similar language in the Fisher bill that's on the agenda today that we do have a cost estimate for, but not a complete fiscal note on yet. So we're waiting that information.
Representative Brindley.
Thank you, Madam Chair. And perhaps Mr. Harney can also explain, looking at this does not go into effect until January 2026. So how would that be accounted for as far as our budget cycles go?
Mr. Harney.
Madam Chair, that would be in the middle of, be the beginning of plan year 26, in the middle of fiscal year 26. So I would assume a forthcoming fiscal note would show an impact half in the next half in fiscal year 26 and the full effect in fiscal year 27 for the added benefit under medical assistance. But without a complete fiscal note, I can't say that for certain.
And Representative Brindley, so we are a little additional information from DHS kind of reminding us too, what this bill is doing is working on establishing a new rate. So until we have that preliminary work and understand what that rate would be, you really can't fiscal note it. So my understanding is that what we would have to do is, this is to do the preliminary work, and then it just comes back to us to see if we want to and can afford to actually do this. So that's kind of my understanding. Is Mr. Harney, do you?
Yeah,
am I
Madam
wrong
Chair,
on that?
I believe you may be confusing the language in the Fisher bill with the language in this bill. So Section 1 of this bill, Subdivision 72, adds an effective date of January 1st, 26, or upon federal approval, whichever is later, for medical assistance coverage for residential crisis stabilization grants. So this bill does establish the pursuit of a benefit upon federal approval.
Yeah.
The Fisher bill and the amendment, after the amendment for the Fisher bill is adopted, doesn't.
Okay, well, that makes it a little clearer. So Representative Brindley, so obviously our intention is if we carry this in the omnibus, we're going to have to fit it into the budget. So we'll have to have it in a form in which we can do that. But I think at this point, we're not really going to be able to know and commit to the rate when we don't yet have any idea what that's going to be.
Thank you, Madam.
Representative New Brindley.
Thank you, Madam Chair. That was a perfect comment, and it probably leads us to understand that this probably isn't feasible for this session because we won't even really have a good handle of the cost. Thanks, Madam Chair.
Well, thank you. And actually, let me just comment a little further on that. So sort of my intention is to get this process started. So I do intend to have a form of this in the omnibus bill because we want to get started on figuring out what this rate should be. We may not be able to commit to implementing it in the future because of our fiscal situation. We don't have a big tails target to do that. But we definitely want to get started because if we don't get started figuring it out, we're not going to ever be able to do it. So that's kind of the intention here. And so there are different versions of this bill, so it is a little confusing, but we'll get it figured out. Representative Backer.
Yes, thank you, Madam Chair. Representative Hicks. It seems to me this bill, does both implementation and studying at the same time. So to me, that's not usual, but mostly you study first and then you implement. Tell me the reasoning behind we're, in essence, doing it, from what I could tell, the same time simultaneously.
Yeah, so.
Representative Hicks.
Thank you, Chair. So we actually have, we have the CERC in Rochester, and I would invite any of you who want to come down to Rochester to come see it. At the CERC, you can stay for up to 10 days when you're in a crisis and get some stabilization. You get therapy while you're there, and it gives your family time to align other services. It gives the county, if there's a need for county support, to start working with the family to identify other supports and other services. So we do have an active model that's working. And we do provide medical assistance payment for adults. We just don't do it for children. But we also, one of the things that is really hard in this body is we cannot quantify a negative, right? So I can tell you that it reduces hospitalizations, but if the person never goes to the hospital because they're stabilized at the CERC, there's not a data point for me to be like, see, it saved $15,000, right? Because it's hard to quantify a negative. But by really taking a look at it, I believe we can. Because if a child spends 10 days at the CERC and it is cheaper than 72 days boarding in an emergency room where they don't see the light for 2.5 months while we try to find an appropriate placement, it is better for the child, it is better for the family, it is better for our community, and it's better for our bottom line. So the reason we're doing it simultaneously is because children cannot wait for us to study their crisis for 3 more years. We don't have time. We have children in this state who have been living in emergency rooms for an entire year of their life. 2 years. We don't have time to study it and then implement it. We already know this works. We have a model. You're welcome to come. I'll take you all. Travis, can they come?
Yes.
They can come. And you can see how amazing this is to work. But I have no intention of being the one who says children have to wait 3 more years for us to work to solve this crisis.
Representative Packer.
Yeah, thank you, and thank you, Representative Hick. So the bill, though, does talk about studying, so I get your perspective there. So what are you going to be studying? It seems from what you're sharing with us, Representative Hicks, you're pretty, already have your mind made up of what needs to be implemented. So to me, and I mean this professionally, it's kind of a smokescreen that we're studying, I mean, what are you studying? Help me understand that. Help us understand that, please. And I'm not here to let you up, Representative Hicks.
Oh, no, you're good.
Representative Hicks.
Thank you. And I know that. I'm just really passionate about this because I'm really devastated for the children and families that are stuck with no solutions because we can't act. The purpose of the study piece is to identify, one, like I said, the return on investment, right? Being able to really say this works. Here's why it works. What are the pieces that work? The other piece is that whenever we're adding a new Medicaid service and whenever we're going to the feds and saying, we're going to try this thing, we're going to do this, sometimes we need to tweak it. And if we don't have a report and we don't have a way to sort of identify where we can make changes, it's really hard to do that. The other piece is that the way we're doing it at CERC is working really well for us right now in this moment. But like all things, we probably have spaces where we can do better. I don't know what those are yet, but I think that if we can fund this service and we can take a look at the outcomes, we can figure out what they are, right? Maybe it's that we add family therapy as part of crisis stabilization. I don't know. Maybe it's that we change the days. Maybe it's not 10. Maybe it's 15. Maybe it's 5. I'm not sure. And we won't know until we make it a Medicaid service where we can really dive in and look at that. And I think this is an opportunity to start that process. As Representative New Brindley pointed out, it is longer than I would like it to be as it stands. But I don't think that it makes sense to wait any longer and say we need to know the perfect to get to good. So I'd like to start with good and work towards perfect.
Representative Packer.
No further questions. Thank you, Madam Chair.
All right, thank you. Mr. Granzi, did you want to add anything? You don't feel compelled, but.
Thank you, Chair Liebling. Maybe one thing to add is that, the current funding model, the services for the youth that are at the CERC and facilities like that across the state, then the bills right now come to the counties, and that's not my point. My point is that when we have a system that's set up like that and that the responsibility then falls to the county, And the county has some input into the authority in regards to whether or not a child ends up in a placement like this. Sometimes counties with less resources then will make decisions based on whether or not a child is placed, based on the money and not on the need of that child. And I think this really, the introduction of this bill and this idea really reduces that too, so that we make sure that the kids that need the service get the service. And it doesn't become a decision in regards to whether or not the county has the resources to make that service happen. So I also think that's an important consideration for this bill. So thank you.
All right, well, thank you, Mr. Granzi, thank you. So we will go now to the amendments. So Mr. Granzi, if you would like to go, you can sit back there. And so I will move the A1 amendment. And this amendment is Representative Hicks, if you would want to go ahead and explain the A1 amendment.
Yes, thank you, Chair Liebling. Like my testifier shared, in the current system, we're putting all of the weight on our counties, and by moving to a CPT code, or moving to a Medicaid service in Medicaid for crisis stabilization, we divide that cost up amongst federal and state dollars. The amendment takes a look at how do we do that for other services in related to CPT codes. So for those of you that are not fascinated by medical billing, CPT codes are the general codes for service billing. And in Minnesota, many of our children's mental health services use H codes. H codes are not used by commercial insurance. So on the Medicaid side, we use H codes for CTSS, and on the commercial side, we use CPT codes. And what that has done is it's created a difficult situation for our providers to create a benefit that can serve both populations. And that's not great for a variety of reasons for kids and for families, but it's also not great for taxpayers. Because if the service that's been created is only does Medicaid, then commercial payers can't access that service, and so people's only option to get the service for their kids is to get them on Medicaid, putting the burden onto taxpayers. And so the amendment asks the department to take a look at that. Are there CPT codes we could be using? Is there a different way to do this to help with the methodology, make it simpler, make it easier for commercials and Medicaid to work together, and easier on our providers so we can serve more kids regardless of how they're insured?
All right, well, thank you very much for that, Representative Hicks. Is there anybody who wanted to testify on the amendment?
I have a provider.
Okay, well, please come down. All right, welcome to the committee. Please state your name for the record and go ahead and give us your testimony.
Shannon Brown. Good morning, Madam Chair and members of the committee. Thank you for the opportunity to testify in support of the A1 amendment. My name is Shannon Brown, and I'm the CEO of Fernbrook Family Center. Fernbrook provides a variety of mental health services across 9 counties in southeast Minnesota. My testimony is on behalf of the voices of many of those providers. This amendment would direct the commissioner to convert billing codes for children's therapeutic services and supports, otherwise known as CTSS, which are currently billed through the Healthcare Common Procedure Coding System that Representative Hicks spoke to being billed under CPT codes. CTSS codes include things like individual, family, group skills training, children's day treatment, treatment planning and development, and a few others. CTSS is designed to provide additional supports to kids whose mental health symptoms are severe enough that psychotherapy alone will not be enough to improve their functioning. CTSS codes allow us to provide more intensive services multiple times a week and provide opportunities for the kids and families to practice the skills they're learning in therapy to ensure mastery and create stability more quickly. Many of the clients we serve in our CTSS program have experienced significant neglect, physical and sexual abuse, changes in caregivers, unpredictable caregivers, among many other things. By providing a more intense level of care with more hours of service, we're able to make progress more quickly and are able to teach skills in the moment while the child is experiencing distress. Many children learn best with repetition and practice and opportunities to practice the things they're learning. And that is exactly what CTSS allows us to do. We create opportunities for repetition and practice of skills. Adjusting the CTSS codes to CPT codes would open an opportunity for commercial insurance companies to cover these services. Currently, very few, if any, commercial insurance companies cover any CTSS services. This often delays or can prevent access to needed care and ultimately places the burden to cover intensive mental health services on Medicaid payers, grants, and the family. Billing these codes under the current system is also an administrative burden for billing teams responsible for sending billing lines to insurance companies. The system is complex and requires many modifiers and additional steps. There are often rejections or additional steps required in order for agencies to receive reimbursement. CPT codes typically are much easier to bill with fewer, if any, modifiers and adjustments needed. Moving these codes to CPT codes continues to move towards a sustainable reimbursement system that enables providers to continue to provide the services that are vital to the overall well-being of Minnesotans. Thank you for your leadership and support.
Thank you. Thank you very much. Is there anyone else who wants to testify on the amendment? All right, not seeing anyone, so we'll go to discussion on the amendment. Is there discussion? All right, not seeing any, so we will then, I will then renew my motion to adopt the A1 amendment. All in favor of adoption of the A1 amendment, please say aye.
Aye.
Opposed? No. The motion prevails. The amendment is adopted. And so with that, Representative Hicks, any final words on House File 4779 as amended?
Thank you, Chair and Committee. Children's mental health is complicated. It doesn't exist in a silo. It's not only in health. It exists across our spectrum. When children with mental health needs do not get those needs met, they end up in other parts of the system, whether that be more expensive residential statements, whether that be in 260C or D in involuntary out-of-home placement, whether that be in a juvenile justice facility, or whether that be out of state. When we do not address children's mental health as an entire continuum, we fail our children. There are many bills this session, and there will be bills in the future, and there were bills in the past. There's not one solution, but this is part of that solution, and it moves us in the direction of truly supporting our children. So I appreciate your time and consideration today.
All right, thank you very much, Representative Hicks. So with that, House File 4779 as amended is laid over for possible inclusion.